This is our technique for doing a cervico isthmic cerclage in case of recurrent late miscarriage. The first step of the procedure is to open the peritoneum between the bladder and between the isthmic uterine level. For that, we have to pull up the bladder and to follow the gas that shows the right dissecting plane. As you see, for this simple procedure, we use classical bipolar and cold scissors, and our goal is to open the peritoneum till we reach the uterine artery, and we'll try to stop the dissection just lateral to the uterine artery. We can identify from this vision the posterior leaf of the brown ligament. We do the same on the left side, small bite of bipolar current, and our goal is to reach the left uterine pedicle. You can see it doesn't matter to do a wide resicovaginal dissection because our mesh will be placed on the isthmic area. Our goal is to identify the posterior leaf of the brown ligament from above. Now it's time to recognize the ureteral direction, which is clearly seen just below the posterior aspect of the brown ligament. We open the peritoneum just above the left ureter and lateral to the uterine artery, and we will try to do a hole between the two aspects of the anterior and posterior brown ligament, like you see. If you follow this rule, the procedure is quite bloodless, quite fast. You can see now, identify clearly the passage between the Douglas punch and between the lateral aspect of our uterine pedicle. This hole will be used for the mesh placement. If you have a small capillary, it's important to do the hemostasis. We see clearly the right ureter location, and we open the peritoneum 1.5 centimeters above this previous one, and we do exactly the same steps that we have done on the left side. Now we open the window between the two brown ligament aspects, and as I said before, we are lateral to the right uterine artery. Now the anatomical preparation is done. You can identify immediately the right uterine artery, the vegecovaginal space, which is a respect, and we can see our bladder. We don't open the Alban fascia, and we can see the left uterine artery and the hole. And as you see, we will place a mesh through this hole from posterior to anterior. Firstly on the left uterine side, and we do the same on the right uterine side. And you can see that the procedure is quite fast, bloodless. We use a 5 mm bougie inside the endocervical canal. That allows us to decrease the risk of cervico-isthmic synetia because we tie the mesh on the isthmic area. You can see we tie the mesh and we do 2 or 3 knots for a good mesh fixation. It's not sufficient to stay like that. we have the use to intraperitonize the mesh, particularly posteriorly, to decrease the small risk of bowel adhesion on the Douglas sponge, and that can be responsible for mechanical infertility. We use for that an Etibond 2O, which is an unabsorbable stitch, and we completely close the torus and we intraperitonize the mesh between the torus and between both right and left uterosacral ligament. We use for that an extracorporeal knotting technique that allows us to win time. And you can see that the mesh is completely covered just above the Douglas sponge. We will place two new knots in the anterior aspect of the mesh for a perfect mesh immobilization. We use the same stitch, Etibond 2O, and anteriorly we prefer to use intracorporeal knotting technique. As you see, if you had a well-trained assistant, the whole entire procedure can be done in less than half an hour. We put a second stitch just medial to the right uterine pedicle, and the stitch is passed through the mesh for a perfect mesh fixation. You can see now the mesh is well fixed on the anteroisthmic area. It's time to do a peritonization. For the peritonization, we have to use to place a monocryl absorbable stitch, which is monocryl 0, with a big needle to do a quick running suture. We begin by the caudal part of the peritoneum, and by a reverse knot we do a running suture, and we arrive at the beginning of our running suture from left to right. For the peritonization, in my opinion, it's a good idea to use a monofilament stitch. You can see now the mesh is completely intraperitonized. So this is our technique for doing a cervico-isthmic cerclage after failure of vaginal cerclage in case of recurrent late miscarriage. I hope the video was interesting for my colleague, and thank you for your great attention, and see you for my next video.